Hello, everyone, and welcome to Global Medical Education CPD webinar series. Uh, Thank you all for joining. Today, we have two presentations. Uh, the first speaker is Amna Khan-Patel, who is a clinical pharmacist, team leader from Bradford Hospital in the NHS UK. And thank you, Amna, for joining. Amna is going to give us a talk on maternal medicine, pharmacist perspective, a very important topic. So over to you, Amna. Thank you.
Hello, everyone, and thank you for joining this webinar. So as Naseem said, my area that I'll discuss today is about maternal medicine and looking at it from the pharmacist's view, and also trying to give you perspective of what you should be thinking about as clinicians, as doctors, whether you're junior doctors, consultants, all the things that you should be thinking about if you're treating a patient, who is pregnant. So some of the objectives that we should look at today are exploring the physiological changes in pregnancy and how this will affect the drug choice when you come to prescribing these sorts of medicines for the patients, and looking at the general principles of prescribing in pregnancy in actual practice. And we'll look at some scenarios and discuss them during the session. And also to understand and look at what resource information you can use when prescribing in pregnancy. Now, this may differ depending on where you are in the world. Obviously, I'm going to base it on our practice in the UK, just for those of you that may be from elsewhere. So firstly, when we're thinking about, maternal medicine and drug use in maternal medicine, we need to think about why it is so important. Now, more and more women are using medications in pregnancy. And another key factor is more women are having children later on in life, which obviously may mean that they have other pre-existing medical conditions, which we need to treat during the pregnancy. So I've got a question actually for everybody. So if you could put your answer in the chat box, and Naseem, can you just let me know what the majority of the answers are? But the first question is, approximately how much of the mother's total body water is increased in the 40 weeks of the pregnancy? So option A is 7 litres, option B is 8 litres, and option C is 9 litres. So if you could all just put either A, B, or C in the chat box, and Naseem, just let me know what the majority of the answers are before I move on to the answer and why. Oh, sorry, I don't think I can hear you.
Okay, sorry. Okay, so some people said B.
Yeah.
Muhammad Sadiq said B. Madan said C. So B and C is, most people are saying B and C.
B and C are the top hits. Okay, well, so those who put B were actually correct in their thoughts there. So it's 8 litres. So when we think about this, we need to consider what this means in terms of drug distribution. Because of this increase in fluid, it means that, it is going to alter the way the drug's distributed in the body. And pregnancy also increases the cardiac output, the rate of liver metabolism, the plasma volume, the glomerular filtration, and also the fat stores. So all of these things will lead to changes in the way the drug is actually used. So it's really important that you understand that before you actually prescribe any mother, medications during the pregnancy. So just moving on to now the actual consequences of these physiological changes. So the drug concentrations in pregnancy are reduced, and we need to then monitor the medications for their therapeutic effect as well as their side effects. So the drug concentrations are actually reduced through a combination of hemodilution and increased distribution, metabolism, and excretion. So teratogens, there are different definitions of what a teratogen actually is. So it's an agent or factor or factors that cross the placenta to cause malformations. And another definition is it's any agent that directly or indirectly causes structural or functional abnormalities in the fetus or when the child is born. Now I'm just going to go through some basics. So drug does not need to cross the placenta to cause fetal toxicity. For example, vasoconstriction of the placental vasculature. And almost all drugs do cross the placenta, and it's mainly by simple diffusion. Now, how much of this actually happens depends upon the actual molecular size, the ionization, the protein binding or lipid solubility. So for example, a non-ionized lipid soluble drug will cross in preference to a polar ionized hydrophilic compound. For example, the more lipid soluble labetalol will cross the placenta to a greater extent than the more hydrophilic atenolol. So that's why you'll see in pregnancy, a lot of people are prescribed labetalol in the UK. And drugs with a high molecular weight tend not to cross the placenta, for example, insulin or heparin, but there are exceptions such as your infliximab. So I've got another question, everybody. So if you put your answer in the chat box, what is the percentage incidence of major congenital malformations in the UK population? So A, 1 to 2%, B, 2 to 3%, or C, 3 to 4%?
Madan says
sorry,
A.
I think A, okay.
Muhammad Sadiq said A. Okay. Most people are saying A.
Most people are saying A. All right, so you probably will be surprised, actually. It's actually B, 2 to 3%. So it's a high proportion of it do cause malformations. But the issue is a lot of the etiology is unknown because the amount of research that's undertaken in pregnancy, it isn't as much as, say, in other areas like cardiac disease or, kidney disease. And sometimes it is to do with the actual maternal health during the pregnancy. So if they've had a healthy lifestyle or not, and this obviously affects what happens to the baby. So another question. So what percentage of malformations are actually caused by drugs? So A, 1 to 2%, B, 2 to 3%, or C, 3 to 4%? Again, just pop your answers in the chat box. I know I'm testing you all this evening, but I wanted to make sure that, I kept it nice and interactive for you all.
Okay, so we've got A, B, A, B. Abhinav saying B, Atizaz Ahmed saying A, Madan saying B. So most people are saying A or B.
Oh, there's a 50-50 split again.
Yeah.
Okay. So the answer is A. So for all of you that have said A, well done. So it's 1 to 2%. Now, when we're talking about teratogenicity, we need to say it's dose dependent and there is a threshold dose. So below the threshold, the drug can be used because it won't exert its teratogenic effect, for example, in carbamazepine. And natural teratogenicity increases with the use of concomitant drugs. So if you're using lots of drugs at the same time, you're going to find that there's an increased risk of this teratogenicity forming. For example, in epilepsy, if a person's on multiple antiepileptics, they are at increased risk of having some sort of malformation. But we need to consider, again, we need to treat the mother first, because obviously if she has got epilepsy, you don't want her to, have a seizure and that sort of thing. So it's about a risk and benefit sort of perspective and a holistic view when you're looking at treating mothers, especially if they have got underlying pre-existing conditions. So this is actually a pregnancy timeline, and the timeline shows the critical period in human development and where malformations can occur. Now, as you can see, from weeks 3 to 8, this is where you'll get your major congenital anomalies. And then from weeks 9 to 36, you're more likely to find the functional defects and minor anomalies. And then, as you can see, there's different areas where it says there's the highly sensitive period. So at the start, when it looks to neural tube defects, and then the less sensitive period, which is from, say, 9 weeks to 36 weeks, when you'll get issues with the eyes and the teeth, etc. So what's really important here is that you understand at each different stage of the actual embryo and fetus developing, there are different abnormalities that can occur, and what's best and how best to avoid them. So this is general prescribing principles that we use in pregnancy, and I'll say this is what we do in the UK because it may differ elsewhere. In all patients, what we want to do as a clinician is to consider the non-pharmacological treatments, because the research into drugs in pregnancy is limited, And, you should only prescribe drugs if it's absolutely essential. We need to consider the period of gestation and, if possible, avoid all drugs during the first trimester, because that's the critical period, when the embryo is developing into the fetus. And if drugs are appropriate, we need to think about using the lowest effective dose for as short a period as possible. We do say to avoid newer drugs because there's little information on their effects in pregnancy. However, for example, with the COVID pandemic and the vaccine, we did need to, make sure that our expectant mothers did have the vaccine, and that did cause a lot of problems because naturally mothers were nervous about having the vaccine because there wasn't a lot of data, but the risk of the mother actually having COVID and being pregnant actually outweighed the risk of not having the vaccine. And that was a lot of work that all healthcare professionals had to do to try and give the confidence to, mothers who are expectant. And we need to avoid all known human teratogens. And again, like I mentioned before, avoid polypharmacy. So avoid giving patients multiple drugs for treating the same condition. Just try to stick to one and make sure that, you optimize the dose and use the safest dose that's possible. So these are drugs which we consider are minimal risk. And even though they are licensed in pregnancy, we don't say they're 100% safe. We just say that they're acceptable to use in pregnancy, because nothing is, 100% safe. You can't guarantee that to the patient. So I would say be very mindful of, when you're having them consultations with your patients, the wording and the language that you use. And it's not to scare them. It's just, to say that the research there isn't the same as within other demographics. But these ones, for example, are considered appropriate and, with minimal risk. So, for example, antacids, paracetamol, penicillins, laxatives and cephalosporins, inhalers for asthma, because what we want to do is make sure we treat the patient for what they're experiencing, because the mother's health is just as important as, the baby's health at that point. Now, drugs which are considered higher risk are things like your ACE inhibitors, phenytoin, isotretinoin, alcohol, tetracyclines, and warfarin. Now, if you actually had a patient in your clinic or on your ward and, they presented being on one of these, high-risk drugs, we'd say at this point, you need to contact, if you're in the UK Teratology Information Service, because that is a nationwide service which main purpose is to look at drugs used in pregnancy. And they're able to offer, advice on what to do in certain instances and guide you as a clinician. So most drugs fall in between. So the patient specific, and you need to look at the risk and benefit for that patient and assess each patient as an individual. So in terms of analgesics, you need to think about, the severity of the pain that the patient's presenting with. If they're in excruciating pain, then you may want to consider, giving them, low dose opioid, but for a short period of time. Or if they can manage with, paracetamol, start off with that, or give them, non-pharmacological advice, say, rubbing the back and that sort of thing, or alternative therapy. Antibiotics, depending on the severity of infections. So there are some antibiotics which we say are, acceptable to use at certain points, but that does depend on which trimester in pregnancy the mother is at, and because that changes in terms of what we know for risk to the fetus, and antiemetics depending on the severity of the symptoms. And when we're looking at this, we need to consider how many weeks pregnant the patient is. Have they taken anything before to try help them, and is it working, or what do they want to get from the treatment? So when we say here is, what is the best treatment for X in pregnancy? Now, we would say that this is actually the first, this question is wrong, because the UK TIS, so that is the UK Teratology Information Service, no longer produce lists in order of choice for conditions such as not vomiting or pain. So prior to this, they used to say, this is first line, second line, third line, but they've actually moved away from that. And the first question is more about what's the best drug for the patient, and then look at its effect on pregnancy. And again, we need to be mindful about the maternal chronic conditions, because they can have negative outcomes on the baby. And also, again, stress and pain are both bad for maternal and, the baby's health. And we need to take into account the normal contraindications and precautions that are there for any drugs, including like drug interactions. And if, say the renal function went off for the patient, again, you need to make sure you're prescribing at the right dosing level for that. So in some instances, the mother may need an increased risk of monitoring for chronic conditions. They might need a higher dose for some drugs, depending on the pharmacokinetics and the changes in pregnancies. And one thing that you must remember is if you have increased the drug dose during the pregnancy, once the baby has been delivered, you need to re-amend that dose at the point of delivery because the mother won't need the higher dose of drug now. So it's just to be careful about that. And again, thinking about principles of absorption, distribution, metabolism, and excretion. So there are lots of concerns of patients, and some of these are based on previous experience of not being prescribed a medication. And there's a lot of information from friends about what they have been given and what they've not been given. And it's about you as a healthcare professional dispelling any of these myths, because sometimes, social media has had a great impact on, how people perceive healthcare and drugs. How many people have come to you and said, oh, I Googled this drug, or I've Googled these symptoms, I may have X, Y, and Z. So, we need to think about how we as healthcare professionals educate our patients. And, we need to think about if other people, some of the things is like some people say, oh, well, my friend took this, that means I can take this. And it's not about that. It's about looking at that individual, assessing their current situation and what they need to treat their own condition. So these are some of the resources that we can use when looking at prescribing information. So the British National Formulary, the SPCs, the summary product characteristics, and that's actually produced by the manufacturers of the drugs, and the patient information leaflets. Other useful resources, I don't know if you've all come across these, are the BUMPS website, and that gives the patient information leaflets. So you can give these to your patients, during the consultation process. Like I said, the UK TIS, so the UK Teratology Information Service. Now, depending on if you work in hospital pharmacy, if you have got a hospital pharmacy service, then you can contact them and they will have additional specialist resources. And if you are in community or primary care, again, you're always welcome to call hospital pharmacies because, we do work with both primary and secondary care as sort of one unit to help making sure that our patients get the best care possible. So now we're just going to talk about a few scenarios, which I'd like you to, well, I don't know if anyone wants to, when I've said the scenario, have a pause for thought and then either, can they unmute themselves to talk, Naseem?
Yes.
Okay, that's fine. So if anyone wants to, I'm going to say the scenario, and if anyone's got any ideas, then please feel free to raise your hand and then unmute and we can discuss this as a group. So a junior colleague asks you which antidepressant you would usually use for a pregnant patient. So in this scenario, what would you do? If you don't want to talk, you can put something in the chat box as well, and Naseem, you can just let me know. Or if anyone does want to put their hand up and have a conversation, that'd be great as well. There isn't one right answer, by the way.
Anyone wants to?
Does anyone want to, before I kind of tell you what we do in our perspective, from a pharmacist perspective? Does anyone have any thoughts they'd like to share?
So Madan says SSRI would be the safest, I guess.
Okay.
Sertraline, Dr. Imran Mustaq says.
Okay. So I'm assuming with them answers, that's probably what they're most used to using in their practice. Now, that might be suitable for the patient, but what I would say in terms of looking at the patient is you need to consider how many weeks pregnant that patient is. Have they taken one before? Did it actually work? Do they actually need drug treatment? Because they may not need drug treatment. They may need, some sort of counselling, and you can refer them to a counselling service, or can they have an alternative sort of therapy? So yes, the answers weren't wrong, but it's just more about thinking about the bigger holistic picture of when we come to prescribing and the decisions we make, and making sure that we've looked at all the different options that are available. Because like I said, drugs should actually in pregnancy be the sort of last choice that we try go for. The next scenario I'd like to discuss, and again, if people would like to put in the chat box or raise their hands, So a 30-week pregnant patient is in agony in A&E following a serious leg injury. She's refusing any pain relief because a friend has told them you can't take drugs in pregnancy. She also knows someone who was specifically told not to take codeine while pregnant or breastfeeding. Now, in this situation, what would you do as a clinician? I'll give you a minute or so to think about it and put anything in the chat box or raise your hand.
Any thoughts? So Muhammad Sadiq says non-pharmacological pain control, immobilization. Okay.
Okay.
Madan says talk to the patient about the acceptable analgesics and then ask OBS gynae for opinion. Okay.
Yeah. That's obviously, reasonable suggestion to make. So in terms of addressing some of the key issues raised in this scenario, and it's the friend that's, advised them not to take pain relief, and your role as the health professional is maybe to consider that, the friend may have got confused in their thoughts, and maybe for that specific friend, they were told they couldn't have codeine for a specific reason. Maybe it's contraindicated to do with their overall health. And then also you need to look at the stage of pregnancy, and it may be different to this patient's particular stage of pregnancy. And codeine, just to note, it can be given in pregnancy. We wouldn't recommend it as first choice, but it can be given at low dose for as shortest period as possible. However, it is contraindicated in breastfeeding. So maybe the friend may be in breastfeeding and got confused because you wouldn't recommend codeine for a patient who is breastfeeding. So I think it's about addressing the concerns of the patient. And again, referring to your more experienced colleagues, like I can't remember which, someone who just said about referring to OBS and gynae, for more advice, which would be, a really sensible thing to do in that point. If it wasn't your area of expertise, it's about using our other specialities, to help in that situation. But again, if you are going to prescribe an analgesic, remember to use, the lowest dose for the shortest period of time as possible, and follow up then again with the patient, either, with the community services or with a follow-up appointment in, the maternity clinic. So scenario 3, a patient tells you she's been taking isotretinoin on and off for the past few weeks. She's just found out she's 11 weeks pregnant and is not sure whether or not she needs to worry. Now, if you presented with that sort of information, what would you actually do? And I'll give you a few moments just to either put it in the chat or raise your hand.
So Etizaz Ahmed is saying ISO is contraindicated in pregnancy.
Yeah, that's definitely true. And if I had a patient that presented to me with isotretinoin, what I would do, especially in the UK, is contact the UK TIS service, because they're the ones who have all of the research and knowledge specifically in the use of these high-risk drugs in pregnancy. And also, if she's only just found out she's pregnant, we're looking at the options and discussing that with the mother about, what they can do, in terms of the pregnancy itself. So I would definitely confer with UK TIS to see what they could recommend in this situation, because again, this would be something that was out of my area of practice and scope. So it's really about knowing what resources are out there and when to actually refer to them and in which scenarios. That was what I was trying to address in this particular case. So that's the end of my actual session, and I hopefully will have covered what the objectives that we were looking at today. So the physiological changes in pregnancy and how it affects drug choice, applying the general principles of prescribing in pregnancy, and looking at what resources are out there when you're actually prescribing in pregnancies. So thank you for listening. And if anyone has any questions, obviously raise your hand or put them in the chat box. And I'm sure Mansoor said, if anyone had any specific questions, you can either email Mansoor or myself, and I can try answer them if you think of something later on.
Thank you very much. It was a wonderful talk, and I know how amazing you are as a teacher and a trainer, because I work with you, and I found your ward rounds really enjoyable, because when you come and join me with the ward round, I know that my medications are sorted for the patient. So thank you very much for that. Sorry, I was just actually had a bit of a problem joining the session, but I did actually be there right from the very beginning. So thank you once again.
No problem.
We will be doing a Q&A session towards the end, if that's okay with yourself and Professor Naqvi. So I would actually have got the pleasure of inviting my colleague Naseem Naqvi. I call him Naseem, but obviously Professor Naqvi for you all, who is actually going to talk about spot diagnosis and clinical observation. Now, we all know that we've actually, especially some of the senior ones amongst us, that spot diagnosis was something that we felt really kind of actually proud of identifying and diagnosing someone, just kind of actually seeing them right from the end of the bed. I think Naseem, you're right in actually saying that this is a dying art, and unfortunately, with some of the training that we kind of actually all do, and for some of the juniors who are going to be consultants in the future, it is more about investigations and relying on the results of those investigations. So really look forward to listening to your talk, and I hope that still a lot of us actually would rely on the clinical acumen and the spot diagnosis, that we all kind of actually feel proud when we get to the right diagnosis. But yes, nevertheless, not dismissing the fact that we all need investigations to kind of actually confirm a diagnosis. So all over to you, Naseem. Thank you. And as I said, any sort of questions that you're dealing or any answers, please do in the chat. I'll be moderating the chat section for this particular talk. Thank you.
Yeah, thank you, Mansoor. So this is going to be a very interactive presentation, and I'm going to be asking you to participate in this. Clinical observation is indeed a dying art. I mean, when we prepare for the exams, when we are junior doctors, we spend a lot of time seeing patients, going to courses, and this is indeed an essential skill, not just for the exams but also in real practice. But I've observed that after a while, this skill is kind of just it dies out, and then we rely just too much on investigations. We do need to investigate, obviously, to get to the bottom of things, but when you are in acute medical unit or an emergency department, these skills help. So I saw a patient recently who was admitted with diagnosis of acopia, so not coping at home, social admission, and admitted from acute medical unit. And when I saw her, she was a bit bradycardic. She had some very coarse skin, some dry hair, and I decided to check her thyroid function, and TSH was extremely high. It was more than 100. She was severely hypothyroid, and it was indeed not just a social admission or acopia, but she was a severely hypothyroid patient. And those of you who work in Southport, they know which patient I'm talking about. And so I decided to share some some cases here. Some of these pictures are from textbooks. They are already in the public domain, so they don't worry about the confidentiality and things, because these are already on Google and in books, etc. So what I'm going to do is I have 20 minutes, and I'm going to show you 20 slides, and I'm going to ask you to participate in this, and let's do this together. So the first slide, what do you see? Is there an abnormality?
Naseem, do you want to unmute them, or do you want them to correct?
No, I think chat is fine.
Chat is fine.
Yeah.
I'll moderate the chat. So please do write your answers in the chat, so I can actually pose it to Dr. Naqvi. I'm sure you can see the abnormality. If not, just describe what you're seeing, or any problems with the hands, any swelling.
Okay, so
swan neck deformity from Ahmed, Etizaz Ahmed.
Yes, Etizaz is right. So this is rheumatoid arthritis hand. Atizaz is absolutely right. If you can see, especially the right hand, and also on the left hand also, there is flexion of the distal interphalangeal joint and slight hyperextension of the proximal joint. This is rheumatoid arthritis. That's right. Okay. Now, this is the same patient whose hands we just seen. What is the complication that has occurred? This is eye, and it looks like this patient has like two.
Okay, so Etizaz Ahmed actually says that this patient's got scleritis.
Yes, this is right. Now the reason is scleritis is because the reason it looks black is because normally it should look white, but the sclera is damaged. So the sclera is perforated, and this is a complication of rheumatoid arthritis. Very dreadful complication. You can lose your vision, and it's called scleromalacia perforans, as the name suggests. Sclera is perforated, and you can actually see the choroid, which hence it is looking blue. So you can see the underlying choroid, and so this is a complication of rheumatoid arthritis, and it's the same patient. Very good.
And Naseem, it does cause a lot of dry eyes, isn't it, as well? With rheumatoid arthritis. Yeah.
Yes, that's right. So there are lots of complications. Rheumatoid arthritis is a multi-system disorder. Now, you see this patient. What is the abnormality? And this patient has mitral valve prolapse. So what you see here is a high arched palate, and high arched palate is not pathognomonic for Marfan's or collagen disorders. It can occur in many conditions, congenital, even just sucking your thumb. Some kids have this habit. It can cause palatal abnormality, but more serious conditions that can cause this are things like Marfan syndrome, Ehlers-Danlos syndrome. This is high arched palate, narrow palate, high arched. Okay, this patient is presented to Dr. Mansoor Ali's clinic with renal failure. And what is the abnormality, and what is the association with renal failure? Okay.
Etizaz, you can come and work with me anytime. So Etizaz says SLE, butterfly rash.
Yeah, Etizaz is absolutely right. Abhinav is right. All of you are right. And Mansoor is going to maybe tell us a bit more. I think it is membranous glomerular, but it can cause glomerulosclerosis and all the different types, isn't it?
Yeah. So basically, this is actually very typical of the rash that we see in SLE. Literally, lupus could be actually sort of how can I say? It just kind of mimics a lot of other presentations, conditions, and it's very kind of actually sometimes difficult to sort of diagnose lupus if you haven't got that in your mind. Lots of times I've actually got the patients that are presented because they've been elsewhere, or the penny dropped when they've got blood and protein in the urine. So when the blood and protein actually is there in the urine with a lupus patient, this patient needs to be referred to a nephrologist. We need to kind of actually do a kidney biopsy, and then the manager is directly and specifically directed to kind of actually the treatment of lupus. So all management will be probably pretty much the same, but lupus nephritis, the reason why you need to act on the treatment, because unfortunately, if not, the patient can progress to end-stage kidney disease. Naseem was right in saying that it actually can cause all sorts of glomerulonephritis. It has got class 1 to class 5 sort of literary forms of lupus, and membranous nephropathy is one of them, focal segmental glomerulonephritis or necrotizing glomerulonephritis. It is actually an emergency. When you find lupus nephritis, you need to treat the patient ASAP. You can't just actually decide to treat them in weeks or months' time. It has to be done to preserve the renal function and the globs.
And Mansoor, is that right, that just like SLE is an incurable disease, the glomerulonephritis is also not curable, but kind of you can treat it and keep it under control?
Yeah, so basically, depending on actually how extensive and how invasive the disease is, basically. So the aim of the treatment is actually to preserve the glomerular function. The aim of the treatment is actually to preserve the kidney function, to preserve the gloms. So I wouldn't say it's completely reversible, but you'll be able to sort of literally stagnate or arrest the progression of kidney disease by lupus. So I've had a patient, just a very brief example, won't take much of your time. I had a patient who's had stable lupus for almost about 10, 15 years. And literally during COVID, she became quite unwell. We, rheumatology and myself, were not aware of the admission. Since COVID, actually, she stopped her treatment. She was on methotrexate, and the GFR dropped from 70 to almost about 30 in a matter of literally 3 to 4 months' time. And then the next review by both me and rheumatologists, we had to come actually biopsy. She's got extensive lupus, and the treatment obviously depends on how do you treat aggressive lupus, usually by immunosuppression like IV steroids and tapering it to oral steroids and cyclophosphamide. So yes, it is actually treatable, it is curable. You shouldn't really come actually let patient progress to end-stage kidney disease unless it is very aggressive lupus and you've tried everything. But there are lots of trials that you can actually put patients into, but usually treatment is aggressive immunosuppression, basically, at the cost of obviously infections and complications associated with lupus and its treatment.
Yeah, exactly. Thank you, Mansoor. Very useful information. Okay, this patient is presented with hypertension. Is there an abnormality?
So Abhinav actually describes this as acromegaly. And
Mother says,
yeah.
Amna Kiran says acromegaly. Yeah, that's right. So this is acromegaly, prominent facial features, prognatism, jaw is prominent, forward protruding, broad nose, very broad hands, as the name suggests, megaly, hands, megaly, broad, wide. And it is again a pituitary tumor, often, which leads to increase in production of growth hormone, and just growth leads to abnormal excessive growth of most organs of the body, not just hands and face, and associated with many complications such as diabetes, hypertension, bowel problems, etc. So that's very good. Okay, now if you know, you know. If you don't know, you don't know. If you know, if you have seen this, whether you're preparing for exam or whatever, you will get it. Otherwise, you will just say that this is just ptosis of the eyelids, some sleepy looking appearance. But there are some very subtle abnormalities also in this picture. In fact, you can see most things. So this is a case of myotonic dystrophy. As you can see, that there is a temporal wasting quite marked. There is sleepy looking appearance because of the ptosis, and also again, this is an autosomal dominant multi-system disorder, can cause dysfunction not just of the muscles of the face, but also skeletal muscles, smooth muscles, myotonic dystrophy, and can cause cardiac conduction defects as well. As you can see, this patient has a pacemaker. If you observe very closely, you can see in the left top chest part of the chest, there is a scar. There's a pacemaker here. They can develop all kinds of cardiac arrhythmias, AV blocks, etc. So the diagnosis is yes. Amna is right.
Yeah, can I just ask you a question about myotonic dystrophy? Obviously, remembering that from my bases and previous, I've probably looked after one patient. Usually was said it was younger patients, with a lifespan of 20, 30, 40 years. But I mean, obviously, I don't know the age of this particular patient, but do you think with some sort of recent treatment or recent sort of awareness of the diagnosis and the management, the patient are living longer?
So the disease itself is obviously incurable. Complications, if detected early, for example, if you have developed a very serious cardiac arrhythmia, it's undiagnosed, you could die from it. You could die from respiratory complications. But detected early, there is no specific cure as such, but you can treat complications better. Like in this case, as we can see, this patient already has a pacemaker, so at least severe bradycardia is sorted. But overall, prognosis is poor, and they develop all kinds of complications, particularly neuromuscular complications, and very classical sign is that they have a difficulty in releasing the grip. So when they shake hands, it's difficult for them to release the grip. So this is again, this is a myotonic feature, very, very, very classical hallmark. So very good. There is a name for this condition. You are looking at the leg, and I want you to tell me at least a couple of causes of this condition and what is it called? Anybody?
So we got Amna Khan saying Badger's disease, Edazar saying bow leg.
Yes, that's right. So this is a bow leg. It's also called saber tibia, saber shin, and it's a curvature in the tibia due to a bone abnormality. And the bone abnormality could be due to Paget's, congenital syphilis, osteomalacia, and other conditions. So yes, that's right. This is underlying Paget's disease, and there are multiple causes for this condition. Very good.
And I think the treatment, if I'm not mistaken, is usually kind of bisphosphonate. So you do corrective surgery as well. Yeah.
Yeah, that's right. So you're looking at this patient. This is a very abnormal looking nose, and something is not right. This is not a normal looking nose. So what are the medical causes? Now, obviously, whenever I show this slide, people say trauma. Yes, of course. But are there any medical causes for this condition? Any medical causes for this condition?
SLE, they're putting down.
Systemic sclerosis. Yeah. Okay. Okay. Any other causes? So again, syphilis.
Syphilis.
This is collapsed nasal bridge, can occur due to a variety of conditions. Cocaine use is one of them because it perforates your septum and other things. Yeah. Yes. All these.
Gamma.
Very good. So these are all the medical causes. So this patient is presented with this patient is being treated for atrial fibrillation.
You've given it away, Naseem, but yes.
Yeah.
Amidron induced.
Yeah, Amidron. So this is a slate gray pigmentation, a classical textbook description, and it gets worse when you go out in sun. And obviously, this is a very severe case. There are not many drugs or conditions that causes this kind of pigmentation, slate gray. Amidron is one of them. But yeah, that's so that's correct answer.
It was Amna Khan-Patel who actually said that. Thank you. Thanks, Amna.
Yeah, Amna Khan is absolutely right. Okay, this patient presented with liver failure, and he is 50-year-old, and he presented with liver failure and also some tremors and some basal ganglia problems.
Okay, so I'm not saying Wilson's disease. Someone else is saying Wilson. Copper deposition in eye from Abhinav. Yeah.
Yes, very good answer. Imran Mushtaq saying Wilson's disease. Yeah, absolutely. So this is Wilson's disease. This is copper deposition in the decimus membrane, in this cornea. You can visualize this well with slit lamp. It is Kaiser-Fleischer ring.
Exactly.
It's described by the two physicians, Kaiser and Fleischer, and that's what it is. Wilson's disease. Absolutely. Very good. Okay, this is another patient. Something is not right. Very abnormal kind of skin. So this patient has a murmur on examination, and he is also at very high risk of some cardiac abnormalities, sudden death. What could be?
Say Abhinav saying allodenus. Yeah.
Yes, that's right. So this is collagen disorder, and
Yeah.
collagen disorder, very elastic skin. It can it affects the collagen, it affects the connective tissues, the connective tissue disorder. So it's a multi-system disorder. It's not just limited to skin. It can affect your eyes, causing lens dislocation. It can affect your heart, aortic regurgitation, even aortic dissection, severe complication, mitral valve prolapse, and other abnormalities. Yes, hypermobility of joints, Ehlers loss, collagen. Marfan's is more fibrillin. Okay. Okay. So this patient is. I'm not going to give you any information. Let's see how many of you will get it. What's going on? So on your left of the screen is the leg of the patient. Is the shin. There is an ulcer there, and on your right there is an investigation. What is the connection between these two? And what is the diagnosis? This is a slightly advanced level question, but these kind of questions come up in MRCP exams, written as well as spaces. An ulcer on the shin, and then a radiological investigation on the right.
So ethizastic dermatitis herpetiformis.
Okay, so this is a good thought, but it isn't, because it is kind of very neck. Paired ulcer. What is paired ulcer?
Peripheral arterial disease, I think.
Okay, peripheral arterial disease. So what is going on the right then? Okay. So this is.
Is it pyoderma gangrenosum?
Yes. Yeah.
With inflammatory bowel.
Very good. So this is pyoderma gangrenosum, inflammatory bowel disease, and on your right, you see this big tube coming, and this is liver. This is a cholangiogram, and we know that inflammatory bowel disease is associated with primary sclerosing cholangitis, PSC, in 80% of cases. And on your right, you see ERCP, because there is a tube there. It's not MRCP because there is a tube. And you see this beaded appearance of the ducts. This is a classical of PSC, a string bead on the string appearance, it's called. And just remember this, because it is very important, this association. Very good. Okay, this patient has ankylosing spondylitis. This is an X-ray of a patient with ankylosing spondylitis. Which complication has occurred? First of all, is this a normal X-ray? Or is this an abnormal X-ray?
Amna Khan-Patel says fibrosis.
Yes. Which part of the lung? Mostly. Primarily.
Upper, it says.
Yes. So this is apical fibrosis. Usually the fibrosis that you see in chronic conditions such as idiopathic lung fibrosis, asbestosis, etc., is usually involving the lower parts.
Basis,
but there are certain conditions that affect primarily the apices of the lung and cause fibrosis. And the easy way to remember the mnemonic is PASTER, PASTER. So pneumoconiosis, ankylosing spondylitis, sarcoidosis and silicosis, TB, extrinsic allergic alveolitis, and radiation. PASTER, PASTER. Pneumoconiosis, progressive massive fibrosis, ankylosing spondylitis, sarcoidosis, TB, extrinsic allergic alveolitis, and radiation. So this is extrinsic allergic alveolitis. Very good. Next is Okay, this patient has AIDS. Describe the right-sided picture and also the left.
So lichen planus from Edin.
Lichen planus appearing as white spots. Okay. Any other thoughts? So this patient is immunocompromised. This patient has AIDS. Oral candidiasis.
Yeah.
Right.
Yeah.
Yes. Very good. And the left is fundoscopy. Same patient. So think about the eye complications of AIDS. CMV on the left. Madan says. Very good, Madan.
Yeah.
You are 100% right. This is CMV retinitis, like flame-shaped hemorrhages.
Yeah. So we also see CMV retinitis, Madan, in our organ immunosuppressed patients, like transplant patients. So I deal a lot with CMV viremias and CMV retinitis, and this is typical of CMV retinitis. And the treatment is actually you need intravenous, valganciclovir or galcyclovir, whichever you have. And also, I think sometimes you need topical injections in the back of your retina as well. Yeah.
Yes, absolutely. Okay, this is a patient. He is only 35 years old. This is elbow. And he is presented to accident in the emergency department with acute MI, massive MI, myocardial infarction.
Tuberous xanthoma from Amna Khan-Patel.
Amna is right. These are lipid deposits in the skin. Tuberous xanthomata.
Yeah.
Sometimes you see them on the eye as well. And just too much. So Etizaz is saying xanthelasma. Yeah, xanthelasma is for the eye. It's the same thing basically. Just lipid deposition everywhere. And these patients are at very high risk of cardiac complications also because of hypercholesterolemia, dyslipidemia. Very good. So same patient. That's his arm, that's his face, and that's his heart. This is ECG. And a young patient. What is the disease? And what complications are happening here? So people are saying
Amna has got answers Lyme disease.
Lyme disease, very good. Why? First of all, can you describe the face? Face is
Bell's palsy, Bell's erythema chronicum marginatum.
Bullseye lesion. Bullseye lesion. Yes, that's right. So Kareem is right. This is bullseye. So it's central erythema, and sometimes the area surrounding the erythema fades out, making it look like a target lesion. This is erythema migrans. It can become chronic, and then you call it erythema chronicum migrans. Very classical of Lyme disease. And yes, and then you have this facial palsy. Yes, of course. And it is lower motor neuron facial palsy because because the upper part of the face is affected, unable to close the eye, the whole left side is affected, and then you see the complete heart block because it can also affect your cardiac muscles and nerve fibers. Yes. So overall, the diagnosis is Lyme disease, which is a viral disease caused by Borrelia burgdorferi, borreliosis, and it is an infection.
Naseem, 1755. We've got 5 minutes left.
Yeah, 5 minutes.
Yeah.
What is this? This is erythema nodosum, shiny skin, painful lesions associated with strep infections, oral contraceptives, physiological causes as well, and also inflammatory bowel disease, etc.
Sarcoidosis, tuberculosis as well.
Yes, that's right. Okay, this patient is presented with seizures. What is the diagnosis? seizures, fits, 45-year-old man.
Yes.
Yeah, so this is neurofibromatosis, right? These are cafe au lait patch. Kareem is right. That's right. 1 or 2 patches are normal, but if you have 6 or more, then it is suggestive of neurofibromatosis type 1. Yes, that's right. All of you are right. Last 2 slides. What is this? This patient is presented with muscle weakness, difficulty to stand up from chair.
Yeah, dermatomyositis said by one of,
Yes.
I think it was Amna Khan, and Kareem says Gutron's, polymyositis ethers, Gutron's papule.
Yes, absolutely. Gutron's papules, polymyositis, dermatomyositis. Okay, this patient, so this is his hands. Anybody?
Gout from Kareem. Arthritis mutilans, Amna Kiran. Gout.
Yeah, it is gout. You can see the tophi. The white bit is just uric acid there. A lot of it.
Gout.
Tophaceous gout. That's right. So thank you. That's the end of my talk. I hope you found it useful. I thought I'd just share, the importance of observation is very important skill in medicine. And please continue to be good observers. Please pay close attention when you are examining patients. Look at their face closely, look at their hands, journal observation. You can save yourself a lot of time and a lot of investigations just by being a good observer. And try and connect the dots, because disease is just how they present. If you don't know what you are looking for, you will never find it. You have to have this conscious awareness, of the various presentations of the diseases. Good observation is still extremely important in medicine.
No, thank you very much, Naseem. I think it was an excellent presentation, and I really found it interesting myself. And to be honest, absolutely spot on actually. Where spot diagnosis and what you said about sort of the clinical observation. Just 2 things to add to that. Obviously, it's also important for the trainees and consultants just to think slightly outside the box laterally, and just always just like what you said about the first example of acopia, but just try to examine your patients. When you examine your patient, you'll find something. And if you don't know, always ask. This is why the multidisciplinary team members are there, actually, where you can ask your colleagues. I'm a consultant, but I still ask my colleagues, actually, if there's something that I've not come across, I've not seen. So always remember to escalate, ask, and think outside the box. I think we've only got a few minutes left. There was a burning question for Amna. So Amna, if you could come back to the scene. And the question was actually about antidiarrheal agent for pregnant patient. And I think it was Mother who was asked that question, saying what the options would be basically for antidiarrheal. Thank you.
So in terms of antidiarrheal medicines, it really does depend on where they are in terms of the stage of pregnancy. For example, loperamide. So, I was referring to some specific resources, and BUMPS is the best use of medicines in pregnancy website, which is available to everyone in the UK to, use as a resource, who work alongside the UK TIS website. And loperamide, there's only been 750 studies into the use of loperamide in pregnancy. So they say that it's obviously not a large enough number of patients for us to be able to say that it's definitely safe to use in pregnancy. However, there is a caveat to that, because if the mother needs the treatment and you need to use it for, like, say, a day or a short one-off dose, you need to assess the risk and benefit of that. Also, when you're thinking about diarrhea, you need to think about the whole clinical picture. Are they dehydrated? Do they need oral rehydration? So things like diarrhea and things, what's the fluid intake and what's the outtake? Are they getting the nutrients that they require? Because especially in the first 12 weeks of pregnancy, with nausea and vomiting and things, they're quite critical in terms of the development of the baby. So if you're a clinician, you need to think about, do they need to be monitored a bit more closely in that sort of setting? So it's not just a simple, yes, they can have it sort of answer. It needs to be considered for that individual patient and what they actually need. And if they do need like a short course, you need to obviously inform the patient, that it's not licensed by the manufacturer to be used, and have that informed conversation with them to make sure that, they understand the risk and benefits themselves. Because obviously we want to make our patients empowered in their decision making and make it a shared decision, because it is an important factor when you're looking at prescribing medicines. And again, you're looking at the alternatives and the whole clinical picture, like I said, about oral intake and that sort of thing. Hope that
and also, well done. And also sometimes actually just look into whether is there something else actually causing the diarrhea? Is it basically? Is it a medical problem? Is it actually as a patient got a viral infection? Was it an inflammatory bowel flare up or something like that, basically? So yes, really important to kind of actually look into the patient, individualize your care to each and every patient. So
just one small question. You mentioned about the hemodilution and the fluid retention and all that. So does that mean that some of the medications will become slightly less effective or need slightly increased dose because there is dilution in the serum?
Yes, because they'll be less effective because you're going to get increased distribution and metabolism. So you're going to need for some doses a higher amount during the pregnancy period, whilst I've got increased volume on board. And then after that, when the delivery has happened, then you need to think about going back and reducing the dose and checking in again, that it's the effective dose, because you won't want to keep them at a higher dose post pregnancy, obviously.
But for medications such as paracetamol, we still take 2 tablets, not 3, right?
Yeah, no, not 3. It's for certain. So I should have said is for certain indications and certain medicines, you may need to think about increasing the dose to make sure it's effective and you're getting that therapeutic effect that you want to see.
Got it.
Okay, so if we've got no more questions, I think we should call it to the end. And I think I was just going to actually just say a few words, just thanking Amna. Thank you, Amna, for coming and presenting today. Excellent talk. And thanks to Naseem for stepping up. Obviously, we had another presenter, but you had to come in and rescue us. So thank you very much. Again, very interesting. Naseem, do you want to, and thank you specifically to Amna Khan-Patel, to Madan, to Abhinav, and to Ehtizaz and Korpotus, who actually answered most of the questions. So thank you very much. Naseem, do you want to make any announcement for the next presentation?
No, so next webinar is next month so I've shared the link to the subscriber link to our MailChimp list. I've shared it in the chat earlier. So if you just subscribe to our mailing list, you will get all the updates of when is the next forum directly to your inbox. But I'll just tell you when is the next one. So the next is on June. GME 19th of June.
Yeah.
19th of June, Sunday, 5 p.m. is the next forum, next webinar, and we'll see you next month. These sessions are recorded. They will be made available on our YouTube channel. Certificate links have been shared in the chat multiple times. It's a Dropbox link. You click on it and then you add your name to it. It's all open access. The link is being shared in the chat, right?
Thank you very much. So have a lovely evening and have a nice week ahead. Take care. Thank you very much.
Thank you. Bye-bye.
Bye.